Yeah, good morning. Am I audible? Okay, perfect. So today's class is on pregnancy with previous LSCS. We'll be looking at the current C-section rate in India. Okay, and then we'll do a brief recap of what the upper and lower segments of the uterus are. We'll talk about the types of skin and uterine incisions. We will do a comparison of the vertical versus transverse incision, and we'll look at what are the rupture rates, uterus rupture rates with various type of uterine incisions. And the most important questions, is it once a cesarean, always a cesarean? We'll look at what is TOLAC and VBAC. And we will also talk about antenatal and intrapartum management of pregnancy with previous LSCS. And lastly, complications of pregnancy in a patient who's had previous cesarean section. So what is the current cesarean rate in India? So the overall rate of cesarean section in India is 17.2%. Now the question is this an acceptable rate? What we need to understand is the WHO had in the year 1994 set 11% as the acceptable rate for C-sections. However, they have made another statement in 2004 stating that there's no such benchmark. Okay, as long as we have favorable maternal and fetal outcome, there should not be a benchmark that C-section should be within this rate. Now, if we look at a tertiary healthcare center like ours, like NEIGHRIMS, C-section rates will always be a little bit more higher because we have more patients who are referred with complications from outside who will definitely need a C-section. For example, if we get a patient who has come in obstructed labor, or we get a patient who's been referred from outside with antepartum hemorrhage, these kind of patients will definitely need C-section. So the C-section rates in the tertiary center is always higher. Okay, now there's a sharp rise in the C-section rates in the past 10 years. 8.5% was the rate in the year 2005-2006, and according to your latest census, the National Family Health Survey census of 2015 and 16, C-section rate is 17.2%. This is very important from your MCQ point of view. Okay, so right now the fifth National Family Health Survey is underway. So by the time you get to your final year, by the time you finish internship and you write your various entrance exams, it's very important that you keep yourself updated. Okay, the current statistics that we have is as per the 4th National Family Health Survey, and according to that it's 7.2, but we expect it to change with the next survey. Okay, so why is there an increase in C-section rates? Like in the earlier slide, I said 10 years back it was 8.5%. We've seen a double-fold increment to 17.2%. So what is the reason for this increase in C-section rate? So there's increased demand of CDMR. What is CDMR? Cesarean done on maternal request. And why is this so? More often than not, we see nowadays women tend to prolong their marriage because of their career choices, okay? And thereby, the age at which they conceive is higher. So we have more cases of elderly preemies, more cases of infertility. Most of these women conceive after IVF, okay? So all these factors lead to increase in CDMR. Most of these women do not want to take a chance. It's a precious baby. Most of them plan for only one child, so they prefer to have something called cesarean done on maternal request. This is one of the main reasons why we have an increase in C-section rates, right? Now, other factors like the use of electronic fetal monitoring, what you have seen in your wards, NST when the patient is still antenatal, or CTG when the patient is in labor, use of electronic fetal monitoring also leads to an increase in C-section rates. Why? As soon as we detect an abnormality in the fetal monitoring, we tend to not take a chance, not delay, and then we tend to pose the patient for C-section. This is especially so when you look at private hospitals. So again, elective cesarean deliveries for breech presentation. Now what you should understand is that the problem with breech presentation, especially in primaries, is the risk of head arrest. Okay, so now once you tell the patients, you explain to them the risk that, okay, we can give you a trial of normal labor, but in case during the process of delivery, there may be a chance of having something known as head arrest. Then again, most of these patients opt to go for a elective C-section as opposed to a vaginal delivery, right? Again, increased litigations. We've seen so many times where we've had something known as stillbirth. Okay, stillbirth happens and some of these patients go to court, and the first question that's being asked is, why was not a C-section done? So this is especially true in case of private practitioners. So because of the increased litigations, they would prefer to not take a risk and do a C-section at the earliest indication. Now these are some of the factors that lead to an increase in C-section rates, especially in our country. So we just have a brief recap of how the uterus functions and what are the upper and lower segments. Now, if you remember, in a gravid uterus, with increased gestation, the uterus also increases in size. And as the uterus approaches term pregnancy, you have something known as your upper segment and your lower segment. This is very, very, very important to understand. The upper 2/3 of the uterus, also known as the active segment, will contract actively. The lower third and the cervix, they become passive. In fact, the cervix is being taken up by the uterus, and this part is passive. Okay. Now, during labor, the upper segment of the uterus becomes thicker. The lower segment of the uterus becomes thinner, and in fact, the cervix, like I said, is pulled upwards. So this is very important. Why? Later on, when we talk about the uterine incisions, the site, the physiology, the reason why we give an incision, why we prefer to give an incision on the lower uterine segment is because of this reason. The upper active segment will actively contract, the lower part is passive, the upper is thick, the lower is thin. Okay, so upper is thick and actively contracts and retracts, the lower portion is thin and is passive. So this is very, very important, the differentiation between your upper and lower segment. Right. So when we look at the sequence of development of segment in uterus, so in a non-pregnant uterus, this is how it would look like. And at term, you have the upper segment that's being formed and of course your lower segment. And like I said, the active segment thickens, contracts and retracts actively. The lower segment thins out and is passive. Okay, again, this is another schematic representation of how the uterus is at term pregnancy, and when the patient's in labor, you have the passive segment and the active segment. So you tell me, Abhijit will tell me, where would you prefer to give the incision? At the upper segment, active segment, or at the lower segment of the uterus? Abhijit, Abhishek. Anyone? Okay, so you try and contract. This is brief recap of your physiology and anatomy, just so that you'll have a basic understanding of what I'll talk later on. Retraction is the progressive shortening of the uterine smooth muscles in the upper portion of the uterus as labor progresses. It is a major feature of uterine contractility during labor. After the cells contract, they relax, but they do not return to their original length. The result is the development of a thicker active contracting segment in the upper portion of the uterus. Now at the same time, the lower segment of the uterus becomes thinner and stretched out. Okay, eventually this results in the cervix being taken up into the lower segment of the uterus and forming a continuum with the upper uterine segment. So like I said, take home messages: upper segment thick, contracts, lower segment thins out and it's passive. So coming to the type of skin incision, this diagram is very, very important. If you can remember this diagram, it will make things very easy for you later on. Now, the most common incision that we give nowadays is the fan and steel incision. The fan and steel incision is a transverse incision 2 centimeters above your pubic bone. Okay. Now, old school obstetricians, of course, used to prefer the vertical midline incision. Now, mind you, this is the type of skin incision I'm talking about. This point is very, very important. Okay. So now, of course, sometimes you can get a short note about to you have to elaborate the various types of incisions, skin incisions, and the advantage and disadvantage of both. Now, suppose you have a patient who's been operated a few years back by a different doctor and she already has a midline incision. Obviously, for cosmetic reason, you'll give an incision over her previous suture line. But in case a patient's a primary C-section, we always go for fan and steel incision. Why? Mainly because healing is better and cosmetic is better. Okay. However, the major advantage of the midline vertical over the fan and steel incision is the midline vertical incision. As you can see here, in case you need to extend the incision, you can go upwards and extend it. Okay, but then the fan and steel incision, the main advantage, like I said, is the healing process as compared to your midline vertical. So the other types of your transverse incisions are, of course, your Joel Cohen and your Maillard incision, but the one that we use in NEIGHRIMS and commonly nowadays is your fan and steel incision. Okay, now this again is very important because more often than not, I've seen students when they give their final year exams. Mind you, NEIGHRIMS is a place where we do more of C-sections and normal deliveries for obvious reasons. Most of the patients who are referred here are complicated cases, so we have to do a C-section. So I've seen patients, so most likely you will definitely get a short case, a postnatal case of a previous LSCS. And the most common question that your examiner will ask you is that, okay, how did you elicit for scar tenderness? Okay, now when we talk of scar tenderness in a previous LSCS patient, we are not referring to the skin incision, we are talking about the uterine incision. Mind you, okay, I've seen students palpating. Now, suppose the patient has had a midline vertical incision for whatever reason. I've seen students trying to palpate along this skin incision, which is wrong. Okay, so this point is very important. So the main type of incision that are commonly used nowadays are, of course, fan and steel. Sometimes in very cases where you're expecting obstruction, there's obstruction of labor and you're anticipating difficult delivery where you need more space, some obstetricians do prefer midline vertical. Okay, but the most commonly used, at least I personally only use fan and steel incision. Okay, so now, of course, the reason why we prefer your fan and steel incision, again, going back to basic anatomy, is because of the Langer's line. Okay, the Langer's line corresponds to the natural orientation of your collagen in the dermis, and because of that, there's better. So incisions made parallel to the Langer's line, okay, may heal better and produce less scarring than those cut across it. So fan and steel incision will be parallel to the Langer's line, as can be seen here, as opposed to your midline vertical incision, which will be perpendicular. So scarring is more with your midline as opposed to your fan and steel, which is parallel to your Langer's lines. So coming to the types of uterine incision. So previously I spoke about your skin incision. Now we are talking about your uterine incision. Okay, these are two different things. I've had a lot of students who have, they see that the patient has had a midline vertical incision and they confuse it with the uterine incision. Okay, so when we talk about uterine incisions, they are basically divided into either your lower segment and your upper segment. Okay. Now, when we say LSCS, a patient has had LSCS, it means lower segment uterine section. And when I talk about lower segment, I'm talking about lower segment of the uterus here, right? So, like I said in your earlier slides, the reason why we'd prefer to give an incision on the lower segment is why it's thinner. So, the healing is better, the opposition of tissues post-surgery, it's better, okay? And then because there's no contraction and retraction that occurs here, there's not much wear and tear here, healing is better, okay? So lower segment can either be transverse, it can be vertical, as can be seen here. Of course, the most preferred mode that we do is your transverse lower segment uterine incision. Then you have your vertical lower section, very rarely done. Now this type of incision is done, suppose if a patient has had a hysterectomy, okay, earlier gestation, she's had a hysterectomy, and because of the lack in space, the transverse diameter is not so much, you may have to give a vertical nick. The other types of incision can be your J-shape. Now, usually J-shape incision is, suppose the obstetrician has given a lower segment transverse incision. What happens is that there's a need to extend the incision for whatever reason. It could be because of obstruction, it could be because of a big baby or impacted fetus where delivery is difficult. Okay, classical C-section is no longer done nowadays for obvious reasons. Okay, because of the wear and tear, the contraction and retraction that occurs in your upper uterine segment, the scar, the healing of the scar is not good, and therefore in subsequent pregnancies the chances of rupture of uterus in a patient who's had a classical C-section. When we talk about a classical incision, we're talking about an incision where? In the upper uterine segment, in the thick, actively retracting part of the uterus. Okay. So this is a classical incision. It's nothing but a vertical incision on the upper segment. Inverted T incision, again, just like your J shape, sometimes what happens is that we've already given a transverse incision in the lower uterine segment, and for whatever reason, if there's a need to increase the incision, we may give an inverted T incision. Okay, this sometimes, even in modern day, we may need to do such an incision in case, like I said, difficult delivery of the fetus. Sometimes in case of malpresentations like your transverse lie, where delivery of the fetus is difficult, we may have to resort to such kind of a incision. Okay, now lower uterine incision, when you give it, it's just not a straight transverse lie. This again is very, very important from your exam point of view. Some examiners even ask you to draw this diagram. It's always a curvy linear or smiley shape incision. Why? As you can see here, these are your uterine arteries, okay, as depicted here. Now, in case this incision extends during the process of delivery of the baby, if it's a straight transverse incision, it can go and you can go and actually injure the uterine arteries on either side, which is why it's very important that you give a curvy linear or a smiley shape incision, so that even if the incision were to extend, it will extend upwards. Okay, so when we talk about a lower segment transverse, even we say it's transverse, it's not a straight line, it's always curvy linear or smiley in shape. This again is a very common question that your examiners like to ask you. So this particular slide is very important. These are the various type of incision. Again, very simple, either divided into your lower uterine segment incision or your upper uterine segment. The most commonly done now is the first diagram, the L. So when we talk about LSCS, when you say that a patient has had LSCS, lower segment uterine, low LSCS means lower segment C-section. Okay, so that means the incision has been on the lower segment. Okay, so when we look at the scar rupture rate in the different types of scar, like I said, classical has the highest rate of rupture. Why? Again, I've already explained to you, upper segment is thick, it contracts and retracts actively. Okay, so because of that, the opposition of the tissue is not good, the healing is not good. So these patients subsequently, especially if they are subjected to labor, if such a patient is allowed to go into labor, chances of rupture are very high, which is why a patient who has had a classical C-section previously, you will always post her for an elective. When I say elective, meaning you will not allow the patient to go into labor. You will do a C-section before her uterus becomes active and contract, because that can lead to a rupture of the uterus. So this is the incidence rate for your classical C-section. As you can see, the low transverse LSCS, low segment transverse incision, the rupture rate is 0.2 to 1.5%. So if a patient were to have LSCS now and she were to get pregnant later on, the chances of her having a ruptured uterus is much lower as compared to a patient who's had a classical vertical upper segment incision or T-shaped scar. Okay, so T-shape, J-shape, classical, their rupture rates are identical. So the most important question, once a cesarean, always a cesarean? Obviously, no. Okay. So earlier on in 1916, Edwin Cragen said that once a cesarean, always a cesarean. Why? That is because in those times, all C-sections, the incision given was always a vertical, classical, in upper segment incision, okay? So which is why once a patient has had a C-section in those days, in the 1916, okay, 1900s, what's happened is that once a patient has had a classical C-section, because of the nature of the incision given on the upper uterine segment, such a patient would always need a repeat C-section. Why? To prevent risk of rupture uterus, okay? But now, of course, the scenario has changed. So it's very important to understand indications of C-section. This is your homework. You're going to read what is recurrent versus what is non-recurrent indications for C-section. As the name suggests, recurrent. I'll just tell you some examples of recurrent indications. Now, suppose a patient comes to you, she's short-statured, you've done her pelvic examination at term pregnancy and you found that she's had contracted pelvis. Okay, she has an anatomical defect of her pelvis where the pelvis is severely contracted. Obviously, you do not expect her pelvis to change in the next pregnancy, right? The bony parameters of her pelvis will definitely not change. Her short stature will not change. So that is what is a recurrent indication. Now, suppose you have a patient who's been afflicted with some muscle deformity. Suppose a patient has had polio, okay, and she doesn't have the power, the force to expel the fetus. Again, such a patient in future pregnancy will still have the same problem. So those are some recurrent indications. Non-recurrent indication. Now, suppose in this pregnancy, a patient has had a C-section done for fetal distress, okay. That is a non-recurrent indication. It doesn't mean that she will have fetal distress again. It could be, but it's not absolute that she will have fetal distress again in her future pregnancy. So that is an example of a non-recurrent indication. So if a patient comes to you, right, she's pregnant, she's had a previous C-section, what are the options that you can give such a patient? So there are two things. Either she can go for vaginal delivery or she will need to have a repeat C-section. It's either one way or the other, right? So a patient who's pregnant, she's had history of previous C-section, she comes to you, it can be either one of these two. So the first one is called elective repeat cesarean delivery, okay, also called as ERCS, elective repeat cesarean section. Classical example is, of course, if your patient has had a classical C-section previously, you do not want to subject that particular patient into labor for obvious reasons. If the uterus starts contracting and retracting, chances of rupture is so high, 4 to 9%. So such patients, you'd like to keep them for elective C-section. Again, if a patient is not willing to have a normal delivery, again in such patients you'd go for elective repeat C-section. So what is trial of labor after cesarean? That is what is known as TOLAC. So either you electively pose the patient for a repeat surgery or you give a trial of labor after cesarean. So TOLAC and VBAC, some people use them interchangeably, but they're not one and the same. So when you subject a patient to trial of labor after cesarean, you're giving her trial. If it is successful, it's what is known as vaginal birth after cesarean delivery, okay, or what is known as VBAC. Sometimes in your exams, in your theory paper, they'll just tell you write short note on TOLAC or write short note on VBAC. So you must know what these terms are. They're not one and the same. Now, if a patient has been subjected to TOLAC, but this failed TOLAC, so such patient will obviously go for your emergency cesarean delivery. Okay, so what is VBAC and what is TOLAC? Like I said, these are very important short note topics. Pregnant women who have previously delivered via cesarean may be given the option to do a repeat C-section or pursue a vaginal birth after cesarean delivery. Like I said, two options, either go for repeat C-section or do VBAC, okay? There are risks that comes along with VBAC and it may be not be advisable for the mother depending on multiple factors. We'll come to that a little bit later, okay? VBAC, the most important increase in risk is the risk of emergencies such as uterine rupture for obvious reasons, okay? Because of the severity of uterine rupture, emergency sections must be performed early to prevent potential damage to the mother and baby. So there have been incidences because of uterine rupture we've lost the mother as well. So TOLAC, it stands for Trial of Labor After Cesarean, and it refers to a planned attempt to labor and delivery vaginally by a woman who has had a C-section in the past. So how does TOLAC differ from VBAC? TOLAC has not resulted in a delivery, while as VBAC means a vaginal birth after cesarean. So this is the basic difference between your VBAC and TOLAC. So for a patient to have VBAC, she must first undergo TOLAC. And if TOLAC is successful, then only the patient is said to have had a VBAC. So which women are best suited to have a planned VBAC? Okay, so planned VBAC or vaginal birth after cesarean is appropriate for and may be offered to majority of women with singleton pregnancy in cephalic presentation at term, okay, at term, who has had one single previous lower segment cesarean delivery with or without a history of vaginal birth. Okay, so we'll come to this. The selection criteria for VBAC, but the most important point from this slide is that it should be a singleton pregnancy, meaning if it's a multifetal, if the patient has had a previous one C-section, but right now she's pregnant with multifetal, it could be twins or triplets, you will not subject her for VBAC. If it is a malpresentation, if it's only previous one LSCS, but the current pregnancy is a breech presentation or a transverse lie, again, you will not subject her for VBAC. Okay, why? Because the chances of rupture with malpresentation is higher. Okay, and very important, she should have had only one single previous lower segment delivery. If the patient is a previous 2 LSCS, definitely the third time will also be a C-section. We do not subject such patients to your normal delivery. So selection candidate, one previous low transverse cesarean delivery. This is so important. If it's even one previous classical or J-shape or inverted T incision, such patients will definitely have a repeat C-section. Clinically adequate pelvis. Like I said earlier, suppose a patient has had contracted pelvis in a previous pregnancy. Obviously, you don't expect anything to happen to her pelvis. Her bony structure will still remain the same. She will still have a contracted pelvis. Again, such patients will be subjected to a repeat C-section. No other uterine scar or previous rupture. Please understand that when you get a short note on uterine rupture, when we talk about rupture of the uterus, there are two types of ruptures. One is rupture in a previously scarred uterus, and the second one is a rupture in a non-scarred uterus. An example would be if a patient comes to you in obstructed labor. Okay, now the uterus is trying to contract, take out the baby. Suppose it's a transverse lie. The uterus is trying to expel the baby, but obviously because of the engaging diameter, the baby is not able to come out of the introitus. Now what happens is that the uterus is exhausted and it's contracting, and because of your active and your passive segment, because of the physiology behind it, there can be rupture. So that is an example of a rupture uterus in a non-scarred uterus. Okay, so when you get a short note on rupture uterus, please mention both types: rupture in a previously scarred uterus and rupture in a non-scarred, for example in obstructed labor. What do I mean by no other uterine scar? Now see, a patient can have a surgery on the uterus before pregnancy. Say for example, she's had a fibroid because of which she was infertile. When she goes for her fertility treatment, they detect the fibroid and they decide to do something known as a myomectomy. Okay, so now what happens? Myomectomy is of course removal of the myoma or the fibroid. Now there are certain instances where during the course of the surgery, the cavity of the uterus is breached. Okay, now we try our best that when we do a myomectomy, we do not go into the cavity of the uterus, but sometimes it so happens that the cavity of the uterus is breached, and in such cases, if the uterus is scar, again, such patients, it's very, very, very important for you that when you take antenatal history, it's very important to ask for history of previous surgery, especially on the uterus, right? Another important point is a physician should be available immediately throughout active labor, because any time that the patient needs an emergency section, like I said earlier, if we need to take her up immediately, baby needs to be out in a matter of few minutes. Okay, and anesthesia and your emergency delivery personnel should be available on floor. So selection criteria, you have 11 points. So these are the points which will enable us to decide whether a patient is fit or not for VBAC. Okay. Type of uterine scar. I think by now all of us will agree that the lower segment C-section is the best scar. Okay, for obvious reasons. The upper classical scar can lead to increased rates of uterine rupture. Now, so the type of uterine scar, the second one is labor with the previous C-section. I'll talk about all these in details. Previous vaginal delivery. Out of all these points, the most important point that will favor, okay, VBAC is a history of previous vaginal delivery. It doesn't matter whether the vaginal delivery was prior to the C-section or after the C-section, but the very fact that the patient has had a vaginal delivery before, that is a favorable point towards VBAC. Uterine incision closure, post-op infection, recurrent indications for C-section, interpregnancy interval, twins, more than one previous C-section, scar thickness, and hospital, facility, and personal. So these are the points that will help us in selecting a patient for VBAC. So the first one, okay, I'll talk about all the 11 points. The first one is type of uterine scar. Classical C-section, 10 times more likely to rupture during labor compared to your lower segment. I've spoken about that earlier. Now, it's very important to understand that such patients may rupture even before the onset of labor. Just the expansion of the uterus with term pregnancy, with increased gestation, that itself can lead to a rupture in the classical C-section scar. So, which is very important. Such patients, when we post them for an elective C-section, we don't even wait for their due date. We just wait for them to cross their term pregnancy, which is 37 weeks, and we plan it before they even reach their due date, because we do not want them to go into labor. Why? Because of this, they may rupture even before the onset of labor. So this is how scary and how dangerous a classical C-section scar is. Low vertical C-section rarely perform. Like I said earlier, sometimes when a patient needs to undergo a surgery earlier before the lower uterine segment is formed, okay, it has formed to a degree but not fully formed. Transverse dimensions are inadequate for the normal transverse incision. I think I spoke about that earlier. So in such patients, you may need to give a low vertical C-section. This is also treated as a classical cesarean scar. Risks of rupture is equally high. So TJ incision, again treated like a classical C-section. Why? Because the incision encroaches upon the upper uterine segment, risk of rupture is higher. Hysterectomy, again treated as a classical C-section. Myomectomy, like I said earlier, if the cavity is opened, such patients should always be subjected to C-section. Now, suppose a myomectomy has been done, but the cavity has not been breached, then such patients can be subjected to normal labor. So previous rupture, it doesn't matter whether the uterus ruptured because of obstructed labor or whether the uterus ruptured because of a previous LSCS. Because of this is a contraindication to subject to subsequent labor. So again, labor with previous cesarean section, we need to understand if the previous C-section was done electively or in the early latent phase, uterine activity in subsequent labor is likely to be of a nulliparous type, meaning in the previous when the previous C-section was done, the patient had not gone into labor, so her uterus was not contracting and retracting as it should be, right? So in the next pregnancy, stronger and longer uterine work is needed to efface and dilate the so-called nulliparous cervix. Why I've said nulliparous? Because that cervix has not really worked in the previous pregnancy. It's not done any active work because a C-section was done. Now, suppose the previous C-section was done during active labor. For example, a patient is 6 centimeters dilated, lower segment is properly formed, cervix has been taken up. And what happens is that then you detect that the patient has meconium and fetal distress, then you take her up for C-section. In such a patient, she has already undergone active labor in the previous pregnancy. So that is known as multiparous pattern. So there'll be less uterine work and strain on the scar in this pregnancy. Okay, this is very important. Again, previous vaginal delivery is one of the most positive factors in favor of trial for vaginal delivery. It really doesn't matter whether the previous vaginal delivery was before or after the C-section, but the very fact that the patient has had a vaginal delivery goes in favor of her having a successful VBAC now. Uterine incision closure, single versus double closure. Okay, so when I was a postgraduate, they say double closure is better. When I became an SR, they say there's no difference. And now the latest consensus is it actually depends on the type of suture that you use and not on the layering of closure. Whether it's single or double, it really doesn't matter. So evidence changes from time to time. Like I said earlier, they said do double closure, then they said do single closure, now again they're saying doing double closure. So it's always an ongoing debate, right? I personally always do double closure, but then they say sometimes it's the material of the suture that matters more than the number of layers. Post-op infection, again, if a patient were to have postpartum endometritis is nothing but the inflammation of your endometrium. Now this would obviously, like any kind of wound, if you have a cut in your hand, you have an infection, the healing of the tissue will interfere with the healing of the tissue. So because of that, there'll be inadequate wound healing of uterine scar. Uterine scar will not be strong, there'll not be too much of scar tissue, and this will lead to an increased risk of subsequent rupture in labor. Right, so the other, like I said, recurrent indications, I've spoken about that earlier. Inter-pregnancy interval, the current consensus is a patient should have an interval of 18 months, okay, after her previous LSCS for her to even be able to go for a VBAC. Now, for example, if you have a patient who's had a C-section done 12 months back, you'll not even think about it, you'll not give her VBAC, she needs to have an elective C-section. But if a patient has had the interval, this is according to your American College of Obs and Gynae, if you've had an interval of 18 months between two pregnancies, such a patient can be subjected to VBAC. Multifetal pregnancy, again a contraindication for VBAC. Malpresentation, again a contraindication for VBAC. More than one previous LSCS. If a patient's a previous 2 LSCS, you will not subject her to VBAC. Scar thickness, okay? 3.5 mm is what we take ideally as adequate scar thickness. Scar, when I talk about scar, I'm talking about the uterine scar, of course, not the skin incision scar. Hospital facility and personnel, like I pointed out earlier, we should have personnel on floor if a patient who is undergoing trial of labor for VBAC, she needs a emergency C-section for whatever reason, we should have facility, we should have a ready OT and ready personnel and ready blood bank, ready blood in hand, okay? So conditions that should be fulfilled before trial of labor, none in current indications. Previous CS, known type, single transverse LSCS, okay? Proper surgical technique, use of delayed absorbable sutures preferred. Smooth post-op closure, no infection. If a patient has had infection, that will of course hamper her wound healing. That can lead to subsequent rupture of the uterus. A long interval between a C-section and current pregnancy, the accepted is 18 months. Current pregnancy, it should be a single fetus in vertex presentation, average fetal weight. Again, if it is macrosomia, if it's more than 4 kgs, we will not subject the patient to VBAC. No medical risk, no history of heart disease, no history of preeclampsia, so on and so forth. No other indications for C-section. For example, placenta previa or fetal distress, okay? Fine. So this is very important from your MCQ point of view, okay? You have your score, which will predict the success of your VBAC. Increased likelihood and decreased likelihood. This is very, very important from your MCQ point of view. So increased likelihood of having a success TOLAC and thereby your VBAC is prior vaginal birth before after C-section. So if you have an MCQ which goes at which of the following features is most favorable to decide VBAC or TOLAC, your answer would be prior vaginal birth before or after C-section. It really doesn't matter when the vaginal birth was, but just having a prior vaginal birth will increase likelihood of having a successful VBAC. Admitted in active labor, again, I had already spoken about that earlier. Nulliparous versus a multiparous uterus. Fetal weight should be less than 4 kgs. Macrosomia, again, decreases the success of a VBAC. Prior cesarean for non-recurring cause, as example, your breech or your previa. BMI, so obesity, again, goes against the success of VBAC. And non-Hispanic white. Decreased likelihood, obviously no prior vaginal delivery. Labor induction goes against, history of having an induction goes against having a successful VBAC. So how do you manage a patient? When a patient comes to you antenatally, how do you manage her? You should counsel her regarding mode of delivery. It's either one of two. Either she'll have a C-section or she can go for a VBAC. But it's very important to counsel the patient at the start of her antenatal checkup. Women should be offered information regarding the need for first cesarean and implication that it may have for future pregnancies and deliveries. Okay. Then the counseling is very important. Now, what we should understand is that even though we counsel the patient, okay, it can either be this or that, but the actual, when the patient actually comes at term pregnancy, that is when we can take active decision whether she can actually go for C-section or not. Why? Mainly because of the presentation. Now, if a patient were to have a breech delivery, okay, it can still be an unstable lie. It will only be stable after she reaches term. Okay, so only after the patient has reached term, and firstly, it's to look at the presentation. Secondly, to assess her pelvis. Okay, so once a patient has crossed 37 weeks of gestation, you'll do a pelvic examination. If you feel her pelvis is adequate, then only you can subject her for VBAC. So what are the additional ultrasound findings you should do, or what are the additional things you should do on ultrasound in the case of a patient with previous LSCS? Fetus number. If it's multifetus, contraindication for VBAC. Lie. If it's anything other than your cephalic vertex, the patient will need to go for a repeat C-section. If it's a breech, or if it's an oblique lie, or if it's a transverse lie, obviously a patient will need to go for C-section. Estimated baby weight, like I said earlier, anything more than 4 kgs, we will not subject the patient to VBAC. Placenta, this is very, very important. Position of the placenta is very important. If the placenta is low-lying, or what you call as placenta previa, it is very, very important to rule out placenta accreta, percreta, and increta. And the absolute, the gold standard for diagnosing this is your MRI. Okay, so why? This is very important because sometimes you miss it, and intra-op is when you find that the patient's having adherent placenta, then you're in big trouble, right? Because there are a lot of things that needs to be done in a patient who's suspected of having adherent placenta. Uterine scar and ultrasound, the accepted range is above 3.5 mm. So I'll briefly talk about the various types of adherent placenta. You have placenta accreta, increta, and percreta. This is a very simple way of remembering it. Accreta attaches, A for A, right? So this is normal placenta, but in case of accreta, what happens is that the placenta attaches, okay, to the myometrium. Endometrium in case of pregnancy is called what? Okay, so in case of accreta, the placenta attaches to the myometrium. Increta, it invades the myometrium, and in case of percreta, the placenta penetrates through the myometrium. It can go up to the uterine serosa, and as well as it can involve the surrounding organs. For example, it can involve your bladder, your bowel. Okay, so the easiest way of remembering it is A for A. Placenta accreta attaches to the myometrium, increta invades the myometrium, and your percreta penetrates, and it can go on and invade the surrounding organs. It can invade the bowel, the bladder. Okay, so this is very important to rule out in the case of previous LSCS. Okay, here you have another schematic representation, right? In case of your placenta accreta, it just attaches. In case of your accreta, it invades, and in case of your percreta, it penetrates. It can go and involve your surrounding organs. Scar thickness, ideally what they do is that they take 3 measurements. They take 3 measurements, an average of that accepted range is 3.5 mm. Okay, so TOLAC, when we subject a patient to trial of labor after cesarean, the most desirable is to allow the patient to go into spontaneous onset of labor. If we do induce a patient, it has to be done with caution, okay, and Cervigel, okay, your prostaglandin, F2 alpha is the most preferred mode. Mesopros, again, evidence changes from time to time, but mesopros only in extreme conditions will we use it. We do not use mesopros ideally in a previous LSCS. Why? Because of increased chance of ruptured uterus. Foley's catheter is another mode of induction that we commonly use in such patients. Parameters to be monitored: maternal pulse. Why? If the patient were to have scar dehiscence because of the likelihood of rupture along the uterine scar, patient can have tachycardia. Patient can have hypotension if there's ruptured uterus. Scar tenderness and CTG are the other parameters to be monitored. How do you elicit scar tenderness? This is such an important picture. I can't stress on it because I've seen so many students in exams, how they falter and how they miss this step. Now, sometimes it happens is that in this case, the patient has had a transverse incision on the skin. Sometimes we have patient who's had a previous vertical scar, and what our students do is that they happily go and palpate along that scar. That's not the way to do it. When I say scar tenderness, I'm talking about the scar in the uterus. And where's the scar in the uterus? In the lower segment? It'll be somewhere around here. So when you elicit it, this is how it should be. Even though the abdominal scar, the skin scar may be vertical, but the way you elicit it, it should always be just above the pubic symphysis. When you elicit it, usually what you do is that you should always look at the patient. You try to talk to her as you palpate her scar here. Talk to her and see if she's wincing. If she's wincing, if she's in pain, you know that she's having scar tenderness. So this is a way of distracting the patient. And despite distracting the patient, if she's still wincing, you'll know that the patient's in pain. Intrapartum management, okay, they should be offered care during labor in a unit where there's immediate access to C-section. There's on-site blood transfusion. You need to have a blood bank facility for continuous fetal heart monitoring. This is where litigation has happened. Some doctors have subjected patient to VBAC in a center where there's no NST facility. Okay, so you would not like to do that. If you're taking a patient for VBAC, she needs to be on continuous CTG monitoring. Okay, and then of course you need to have your senior obstetrician, anesthetist and pediatrician on floor 24/7. Continuous fetal monitoring is recommended following the onset of uterine contractions for the duration, throughout the duration of TOLAC. An abnormal CTG is the most consistent finding in uterine rupture and is present in 55 to 87% of these events. So intrapartum monitoring, CTG is very important, and of course maintaining a partogram, because if a patient has a delay in progressive labor, it can mean that she's going towards obstruction, which is something you would totally like to avoid in a patient with previous LSCS because of the increased likelihood of the patient going to ruptured uterus. Complications, the most dreaded complications, of course, your uterine rupture. The types are, again, in a scarred uterus, it can be scar dehiscence or complete scar rupture. Dehiscence means herniation of your intact amniotic membrane into an existing uterine scar. In a proper scar rupture, there's separation of scar along the entire length, often with involvement of the amniotic membranes. Okay, so this is a schematic presentation of how a rupture can be. Your uterine arteries is here. And if your incision, and then what happens is that it can go and it can actually injure your uterines on both sides, and this can lead to catastrophic hemorrhage. Right? So this is in case of a classical scar. Okay, it's more likely to rupture as compared to your lower uterine segment transverse scar. Clinical features, very, very important. A patient will have severe constant abdominal pain. There is, however, cessation of uterine contractions for obvious reason because of your loss of uterine contour. Vaginal bleeding, which may be severe. Maternal tachycardia, which is why maternal pulse monitoring is very important in such patients. Hypertension, shock may be out of proportion to your vaginal bleeding. Hematuria, bladder injury is seen up to 25% of cases in ruptured uterus. Fetus may be palpable in the abdomen. As shown here, what happens is that when there's complete rupture, the baby can be totally out of the uterus, and then you can palpate it perabdominally. Okay? So to conclude, C-section forms 17.2% of deliveries in India. The most preferred type of C-section is the lower segment C-section. Why? Because it has the least chances, the least rate of subsequent rupture in future pregnancies. VBAC, the most important criteria to decide whether VBAC will be successful or not is a history of previous vaginal delivery. It doesn't matter whether the vaginal delivery was prior or after the previous C-section. And the most dreaded complication of VBAC is your uterus rupture. Okay?